The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMD Demystified Podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMD Demystified Podcast.
Here we are again for the next episode of TMD Demystified. It is in my world Tuesday afternoon, and I am Tony Urbanek. Today's topic is very important, as in most of the topics I choose. The title for today's discussion is Anamnesis is critical to the diagnosis and treatment of TMD. Anamnesis is critical to the diagnosis and treatment of TMD. Now, I know I threw you a curve. I bet you're all wondering, rolling your eyes, looking, what the heck is anamnesis? Maybe some of you know. If you do know, you are on the more astute side of your profession. So I won't hold you in suspense. Anamnesis is derived from the Greek, as in a lot of medical, Greek or Latin. And anamnesis basically means the case review or case history of a patient. Case review or case history. It is very important that you take a case review or case history that is meaningful when you're treating TMD. It's very easy. What I'm having to say, I don't mean to complicate it. I really don't. And I use the word anamnesis, and I'll define it for you. In medicine, anamnesis, A-N-A-M-N-E-S-I-S, anamnesis is the process of gathering the patient's medical history to help determine the cause of an illness or injury. It is also known as a patient's case history, derived from the Greek ana, A-N-A, meaning back, and mnesis, or nesis, meaning recall back. It has many advantages by taking a good medical history, dental history, mainly medical history and symptom history when it comes to TMD. You know, as a dentist, and I assume that almost all people who view this podcast and view these episodes are in the dental industry. Most of you are dentists. I don't mean to be pedantic, but that simple word describes what is truly a good medical history. Now, there are several parts to a medical history. I don't want to dissect it excessively or unnecessarily, but the first part is to collect symptoms, just the symptoms of the problem. And the second part would be to collect the general medical history of the patient, which frequently have an impact on the other areas of the patient's history or body, or an effect on the symptoms themselves. So there's really many different advantages to taking just a few minutes. It does not have to be complicated. You're not at a disadvantage because you spend your life in a dental office rather than a medical clinic. I assume most of you, unless you're a double degree oral or maxillofacial surgeon, do not have much familiarity with treating patients' medical conditions. But if you're taking a reasonably good medical history along with your dental history, you're exposed to the majority of the usual and customary illnesses that people have. And of course, you were exposed in your basic sciences in pathology and biochemistry and anatomy, physiology. Not sure how much you remember, but it is important, especially important in sorting out this thing that we call TMD. Anamnesis is critical. A good medical history and a good symptom history is critical, and it is very satisfying. It isn't extra make work, and I'll explain why in just a minute. So we've covered the definition of this word. And by the way, I hope I didn't make you feel too bad when I gave you the title to this episode, because if you go past a word you don't understand, pretty much everybody goes blank afterwards. And you start to actually feel bad. And when you continue past that point, you pretty much can't even follow what is being said or read. So I just bring that point, and I did it intentionally. I could have just called it a good medical history is critical to the diagnosis of and treatment of TMD. But it made the point, hopefully to some of you, when I use the word anamnesis, that it is very critical that when you are working with a patient or working on a topic or reading a medical journal or any other kind of medical topic, to make sure you understand the definitions of the words you're reading, or you're just going to go blank and feel bad. So a good history is critical. First of all, there is an earlier episode, I can't give you the number offhand, but where I covered what a proper TMD history looks like. Literally, I videoed myself doing a history. You can go back and review that, but we're going to talk about it a little more in depth at this point. It is very important, number one, to give the patient the first opportunity to give you their rendition of what is going on. Everyone has a little different personality, both patient and doctor, but I am emphasizing the fact how important it is for after you walk in a room for a consultation with a patient you have never seen before, and almost always when you have a consultation with a TMD patient, you are never seen this patient before. Unless they are a historical patient in your practice, but most of these patients filter in from outside of your practice, certainly the way it is here in this practice. It's important that you introduce yourself, do whatever pleasantries you'd like to do, and then sit down and ask the patient to tell you about why they're there. What are the symptoms that they are trying to resolve? And let them talk, hopefully not too long. If it gets too long, then you can cut them short. You can lead them a little bit, but listen to them first until they've satisfied that they've been able to tell you their story. In the area of TMD, I can promise you some of these stories can go on for more time than you want to sit there and listen, and that is true. So I have my methods to somewhat cut the patient short, and I tell them I'm interested in what you have to say here, but what I'm really interested in is symptoms, not how many doctors you've been to or what all the other doctors had to say about this, or what other treatments that you were used and all the descriptions of the treatments and how they did this and did that but didn't work. Well, that's nice to know, I guess, but not necessary at all. What you're interested in is basic symptoms. And then as the patient gets to speak, give them the first opportunity. Not only will you learn what symptoms that they have, but you will learn something about symptoms that you may not have been familiar with, or symptoms that may or may not be associated with TMD, and you'll be able to sort out later. And I'll speak again in a minute or two, in a few minutes, about how to do that. This is, once you catch on how to do a good consultation, it should take you no more, maximum 20 minutes, most of the time 15 minutes. Probably a 10-minute consultation is a little too short. Somewhere between 15 and 20 minutes to do an ideal full consultation regarding TMD, and that includes, most of that includes taking the history. So give the patient the first option to tell you what their symptoms are, and then next, explain to the patient where you want to fill in the blanks of what other symptoms might be there that they may not even be aware of, because so many times, like very often, going through the proper symptom list of TMD, the symptoms, well-known, well-established symptoms of TMD, the patient will look up and they would say, I had no idea that that particular, or these symptoms were associated with my jaw joint problem. I just thought that this pain up here was the pain up there. I didn't know that my neck pain was caused by this joint thing going on, or that my ringing in my ears is caused by this joint thing that's going on. So again, as I've said and reeled off so many times, but it is appropriate for this episode to reel off the actual well-known, well-established symptoms of TMD, which are frequent or recurring headaches, frequently misdiagnosed as migraines, frequent or recurring earache, something that feels like deep ear pain, frequently diagnosed as ear infections, which are not infections. It's TMD inflammation. Pain that goes down the back of the neck, side of the neck, or forward into the jaw, either neck pain or jaw pain, one or both sides. Upper back and shoulder pain and tightness, which is, I believe, the second most common symptom of TMD is upper back or neck pain or tightness. Ringing in the ears or buzzing in the ears, tinnitus. Subjective hearing loss, feels like your ear's full of water when you haven't been swimming. Vertigo, dizziness. Arm, hand, finger tingling and numbness, and various kinds of locking of the jaw. Those are the well-established symptoms. And the question that you would ask the patient once they've given you their symptoms and you've picked out, maybe they say, I have headaches every morning, it hurts there, or it's here. So you know what they have, that symptom, but then you ask them, do you have, or have you ever had any of the following symptoms? Headache, earache, jaw pain, neck pain, ringing, fullness, dizziness, upper back and shoulder pain, arm, hand, finger tingling and numbness, and various kinds of locking. And they will either say yes or no, at which point two things happen. Number one, you have a complete view, how broad is their symptom complex, and they start to realize that there is a lot more to the symptoms that they're having and goes well beyond whatever the symptom they came in for. And there are a few others I can talk on. I mean, dental pain is, patients frequently say that it feels like their teeth hurt, but it's not coming from their jaw joint. And they claim that it feels this, it must be a toothache. And some of them even talk dentists into taking out a few teeth, and then they come in with some missing teeth and they still have the symptoms of TMD. It's a learning experience. The point is a learning experience for both patient and doctor. And the more you do it, the more you feel comfortable doing the consultation, more comfortable treating the problem. The patient begins to feel more comfortable with you as the doctor. They are not as skeptical as they would be frequently with this problem, because patients come in with a prior history of TMJ, quote, TMJ, TMD, skeptical as heck, because they know that nothing has worked so far and they heard nothing works. And the consistent, paradox about this is that, it's a problem nobody knows anything about, nothing works, which is totally not true. The point has been missed. It's all about inflammation in the joint. And go back to prior episodes and listen to my discussion on that issue. So you learn from your patients. Now, that is just covering the symptoms, and get them in the chart. It's very simple. Or convert it, to the chart after the patient leaves. It's only, 10 major symptoms, and keep them in mind and put them in your chart, because those symptoms are very important for you to document. Document the symptoms. If you're going to market this, you need to document the symptoms. Use those symptoms to market to other potential referral sources when you write your letters to potential referral sources, telling them that their patient, Molly Jones, came in with such and such symptoms, and now at 3 weeks says 70% of those symptoms are diminished or gone. See, extremely valuable marketing tools that I spoke on in prior episodes extensively. So you want a complete list of the symptoms, and then you want to have a relatively full understanding of their medical history, because a lot of times, again, it's an opportunity for you to learn. And fortunately, we have this tool at our beck and call, that if the patient gives you a drug or a procedure or a diagnosis from some other medical provider that you're not familiar with, it literally takes, you wouldn't want to do it in front of the patient, but just make a mental note or a jot on your physical notes to look it up. It'll take you 30 seconds. You'll get within 30 seconds, you'll have a viewpoint of what that lack of knowledge is, and it'll fill in the blank. And the next time the patient comes in with the same history of medication or procedure or surgery, you will know a lot more about it, and it'll make a lot more sense. So taking a good history is very important. TMD is an opportunity to bring together your medical knowledge and your professional referral sources medical knowledge, along with your dental knowledge, and integrates dentistry and medicine. Again, it's not hard. It does not take a long time. You don't need to be afraid of it at all. And the fact that it is so critical then into actually making your diagnosis, and then once your diagnosis is made, in treating the patient. So here's how it works. If the patient comes in and they have several of those symptoms that I now have reeled off twice, you are suspicious that they probably have TMD, but only suspicious. At which point then you will do a little very brief examination, opening the mouth, seeing how far they can get their mouth open, seeing whether they have evidence of bruxism or trauma. Let the patients talk about any traumatic events, but open the mouth, especially look for torii, mandibular torii, palatal torii, or lateral exostosis, which by themselves are proof that the patient bruxes. A lot of people have torii, they don't know that they brux. And torii, or lateral exostosis, are absolute proof that the patient bruxes. You can't develop those bony exostoses, both torii and exostoses, without bruxing. Not many dentists know that, although because of this episode and similar episodes in this podcast, a lot more doctors are becoming aware of that. You want to see how far your physical examination, how far can they actually open without pain? And if they do have pain, where does it hurt? And then finally, does the tip of the coronoid process, is there pain there? Stick your finger up along the ramus to the tip of the coronoid process. Almost all people with TMD will elicit pain when you touch the tip of the coronoid process, because that's the insertion of the temporalis muscle, the most common muscle to get tight. When it gets the signal to get tight, it'll pull on the bone here and pull on the coronoid process. And when you touch the coronoid process, it'll be tender, which by itself does not make the diagnosis. But what makes the diagnosis is then to stand behind or beside the patient, ask them open widely, push in the glenoid fossa firmly with your fingertips, and have them close rapidly one time. If the joint hurts, the joint's inflamed. If the joint doesn't hurt, the joint's not inflamed. The definition of TMD is inflammation of the joint. So, getting back to history, getting back to anamnesis. Your history, your anamnesis lays the groundwork for you to be suspicious. It also lays the groundwork for you to learn about the other aspects of this disease and use your medical knowledge and your medical training and to help these patients. when it gets into treatment, then you now have a list of symptoms collected at your history associated with TMD, and then you can ask the patient at each follow-up visit what percentage of those symptoms that you now list out for them. You know their symptoms. You have garnered their symptoms, whether they gave you initially and when you sat down and listened at first, gave them the first opportunity to tell you about it, or whether then you went into stage 2 where you ask them what symptoms on that list do you have. You have that full list of symptoms, at which point then you can ask them at each follow-up visit what percentage of those symptoms are gone. Average it out. Take all those symptoms, lump them in a pile of symptoms, average it all out, and tell me what percentage of those symptoms are diminished, decreased, or gone, in your opinion. And stay silent until they can come up with an answer, or encourage them, they can't understand what averaging is, to explain what averaging is to the point that they can throw out a number at you, and follow that number over the treatment plan over the next really no more than 3 months, 2 months, 4 months. You'll see that those symptoms will start to decrease. That single number will decrease. If you want to waste your time by asking about each individual symptom, you can do that. Sometimes I will ask, what symptom have you noticed the most improvement on? Not how much. The key is how much of the symptoms are gone. You can quantitate that nicely. Patients can quantitate how much is gone much better than how much better it is. So you quantitate how many or much of the symptoms are diminished or gone. And then if you feel like you need to, you can say, what symptom do you notice the most improvement on? And they'll throw out, whoa, my jaw pain is so much better, but my neck is still having some problems. Okay, that's fine. Or you can ask them, what is the symptom that you notice the least improvement on? Oh, the ringing in my ear is still going on, which is expected because of the tinnitus is almost the last symptom to leave, and may take many, many, many months on the tinnitus, where headache and earache and jaw pain start to go down within the first week or 2 after starting treatment. So, anamnesis, from the Greek, to remember back, and ask the patient and be patient with the patient. Let them speak first. That's critical. And do it from a sitting position, because from a standing position, you're intimidating. Try not to intimidate your patient. And then once you get their rendition, now ask for the symptoms, which is both an education to you and an education to the patient. And it builds trust and it decreases skepticism. And when you finally get to the point where you explain what the treatment is and how simple it is and how it works, they are much more likely to accept treatment and to get on with it so they can get rid of their symptoms. That's the whole point of this, to get rid of the symptoms in the most easily effective, transparent manner. All right. I'll leave it at that. I encourage comments or criticisms of what I have to say. If you'd like to talk with me, I'll be happy to communicate with you easily. I can be reached at tony@tmjservices.net. If you'd like to learn more about what we do at tmjservices.net and how this problem has been solved, and I say that with emphasis, and knowing that the amount of skepticism out there is significant in the fact that TMD has been solved, but the problem has been solved by knowing the common denominator, which is inflammation in the joint, creates all the symptoms. With this little device, which separates the back teeth, according to a protocol, and the device itself having to be made correctly, which brings me to probably next week's episode, which is, I'm not sure what I'm going to name it, homemade devices, because the word is out there, and we are getting more and more feedback from doctors and even patients who take their night guard or make a homemade night guard, put on some extra stuff along the front teeth, and call it treatment. And there's a big difference between this device and just something that separates the back teeth by putting a wad of plastic up there or cutting the back end off of a night guard. Because we see the patients that come in and it's like, I'd cut off the back of the night guard. It doesn't work. Different topic for a different day. I am open for discussion. I'm open for criticism. I would like to hear from you. If you have questions, I'll be happy to talk with you. If you'd like to join the network of doctors who do this service using a patented, FDA-cleared, university-tested device with success rates in the 90%, as long as the patient will follow the protocol, you can look at our website at www.urbanektmj.com. I look forward to the next episode. I think I've given the topic away. I think that's what I'm going to do next time. Until then, I'm Tony Urbanek, and this is TMD Demystified.